Here we go with some wrongs for pediatrics. Can be a little bit on the shorter side in terms of questions wrong. Got 7 wrong, but going to possibly try and dive in a little bit harder on what we got wrong. So first one was a girl with bilateral ear involvement, 2 years old. They're saying no management needed at this time. This is in a little bit contrast to a UWorld question where the patient had bilateral ear involvement, or they were calling it straight up acute otitis media. And this patient, they're saying, is otitis media with effusion. So in this case, because they feel confident to call it otitis media with effusion, then they're saying no management is indicated at this time. Their explanation is that otitis media with effusion commonly manifests as sequelae of an upper respiratory tract infection or acute otitis media with evidence of a middle ear effusion in the absence of middle ear inflammatory findings. Dysfunction of the eustachian tube is the underlying cause. Most cases tend to be self-limited. In this particular case, she had 5 days ago, she had just completed a 10-day course of amoxicillin for acute otitis media of her right ear. She'd had 3 episodes of otitis in the past, with no allergies and immunizations being up to date. When you did exam, you found the tympanic membranes were pearly gray and retracted, and there's decreased mobility bilaterally. Without the inflammatory component of this, they are not going to let you do any of the antibiotic options. They're going to keep you with no management being indicated at this time. So simply the fact that they have bilateral involvement isn't enough to move on to any sort of antibiotic option. Next is a development question. These just are like you either know it or you don't. It says 4-year-old boy can imitate straight line but cannot copy circle. Combines words, only half of his speech is understood. He can jump but cannot balance on one foot. Physical exam has no exam or abnormality. What is the accurate assessment of the patient's development? And it turns out that they're delayed for everything. At 4 years old, they are delayed for everything. So this bucks the trend of the normal that happens pretty often, but they're calling this patient to have a global development delay. And that a 4-year-old child should be able to hop on one foot. They should be able to copy a square and simple stick figure, and they should be able to speak in sentences as well as play cooperatively with friends. So only half of his speech being understood, that must be not enough for what they want. And they should be, because he should be able to speak in full sentences and be understood by others. In terms of imitating a straight line, he should be able to do all the way to a square at this point. So the straight line isn't enough for him. Not being able to do a circle is also just not enough for the 4-year-old. And then being able to jump is great, but if he can't balance on one foot, then you can just forget it. He has a gross motor delay, because at 4 years old, he should definitely be able to hop on one foot. Here we have a kid with a kidney issue. These seem to be contentious for me for some reason. It's saying, what's the next appropriate step in diagnosis? And they want you to measure serum C3 before you've done a renal ultrasound. And that's just not normally how things go. You're going to do a renal ultrasound before you get a serum C3. But I guess maybe you could make the argument you do it concurrently. Saying that she has acute streptococcal glomerulonephritis, a type of nephritic syndrome that has dark colored urine, hypertension, hematuria, and proteinuria following an infection with group A strep. Immune complex deposition with glomerulus and mesangium would lead to decreased serum C3. Absolutely. I mean, I could not agree more. But you just cannot tell me that the next step would not also involve a renal ultrasound, because you're going to have to visualize and get that set for monitoring the progression of the illness. So there's just no way that there's no way you're not going to do a kidney ultrasound here as well. Sodium was slightly low, potassium was slightly high in this patient. BUN was ever so slightly high, creatinine top end of normal. And they had 2+ blood, 1+ protein, with too numerous to count red blood cells. Not a crazy case. She has post-strep glomerulonephritis. They wanted to do a measurement of serum C3. You can keep in mind that they could have generalized edema like periorbital to pretibial and pedal edema. Those all possible findings in somebody with post-strep glomerulonephritis. Keep in mind that if they have viral rhinosinusitis, it can turn yellowish. It says that it was clear at first and then turned yellow. We didn't get this one wrong, but just always a friendly reminder. Started clear and got yellow. Well, it doesn't necessarily mean it's not viral rhinosinusitis. For Angelman syndrome, they are saying that the way they want you to read it is that it's a chromosome 15 deletion maternally inherited. That's kind of confusing because you're inheriting getting the deletion. So it's like you don't have the maternal copy. So that's why it's maternally inherited, that you don't get the maternal thing. So I'm not sure that wording is maybe a little confusing to me, but suffice it to say, Angelman syndrome is a genetic disorder caused by a microdeletion of the maternally inherited chromosome 15q1113, and that has the gene UBE3A in it, which affects the hippocampus, cortex, and cerebellum. So you have a reliance on the they're saying that you have a reliance on the maternally inherited copy for normal development, but you don't have the maternal copy. So I guess that's why you're not getting normal development. Wording here is a little weird, but that's what they want. Fresh frozen plasma, if somebody's low on K. We didn't get that wrong either, but low on vitamin K, consider fresh frozen plasma. FFP gets the K. They don't have to tell you that there's a physical exam finding for pyloric junction. You commonly get the olive mass or slight mass at the epigastric region, but they don't have to give it to you. If the vignette fits for pyloric junction, then it just fits. Erythema toxicum, again, we didn't get this one wrong, but erythema toxicum could be described as a generalized rash with small yellow papules on an erythematous base, predominantly over the trunk. That just goes away on its own. You don't need to do anything for it. Not crazy. This one we got wrong. So it's a 3-year-old boy. He came to the emergency department 4 hours after the onset of irritability and temperatures getting up to 104 degrees. So it makes it seem like it's acute onset. He does have a chronic condition of juvenile idiopathic arthritis that was diagnosed 2 months ago. I think they're insinuating that this was possibly done incorrectly, because now the patient has a palpable liver edge as well as a palpable spleen tip 5 centimeters below the costal margins and a low leukocyte count that's lymphocytic heavy. And then they're going to go with this patient having acute lymphoblastic leukemia. So because they have fever, petechiae, lymphadenopathy, hepatosplenomegaly, and laboratory findings of pancytopenia with the predominance of lymphocytes, they are basically saying that it's a good chance to have ALL, and then the only way to confirm that would be bone marrow aspiration. I'm just going back over this. So they're saying that they have diffuse lymphadenopathy here. I picked an abdominal CT, and that's going to be only helpful for finding intra-abdominal tumors such as neuroblastoma or nephroblastoma, and this patient's hepatosplenomegaly is likely secondary to the leukemia rather than a primary intra-abdominal pathology. Very reasonable diagnosis is confirmed with bone marrow biopsy that shows more than 20% lymphoblast on the bone marrow biopsy. Now we have common variable immunodeficiency in a 12-year-old. I feel like I've always seen this happen in the 20s or early 30s in age group. And for some reason, they found that it was fine to do it here. Um, in the explanation, it says common variable immunodeficiency is a primary immunodeficiency syndrome, the class that presents in the second to fourth decades of life with recurrent sinus, pulmonary, and GI infections. Laboratory studies will show low concentrations of all immunoglobulins. And they were all low. It just felt like still that would fit X-linked A gamma globulinemia, which is mutation in the BTK gene that encodes tyrosine kinase. But that would nearly always present within the first 18 months of life with recurrent infections and is more common in males given the fact that it's X-linked. This is sort of like, what rule are they willing to break more? It seems like they're more comfortable breaking the rule that CVID, common variable immunodeficiency, would happen earlier than maybe what you were expecting, as opposed to Breton tyrosine kinase gene being missing. That's probably not going to present in a 12-year-old, and it's definitely less likely to present in a 12-year-old girl. I believe we have one more here. No, that's it. Yes, we do. The last one is a 6-month-old boy who comes in for a well child, and he has poor growth development, and they're saying that he has gastroesophageal reflux disease, and we picked pyloric stenosis. Pyloric stenosis had already been the answer like 3 times before this. Certainly, when you're taking a 300 plus question test, it's a little bit less likely to keep seeing the same thing and then actually care about it. But on the 50 question test, if you see pyloric stenosis 3 times, then you do start to freak out. But we had a question earlier where the patient was only 2 months old, and then they had no mass, no findings on physical exam. This patient is 6 months old now, significantly older. And they also don't have any physical findings except for a decrease in sub-Q fat. So it's kind of interesting that they just started to fall off the growth chart ever so slightly. Over the course of 2 months, they had fallen from the 50th to the 35th percentile on weight, and they had just been spitting up a lot. They're saying gastroesophageal reflux was common in infants. In terms of pyloric stenosis, they're saying it typically presents at around 3 to 6 weeks of life. In this patient's 6 months, and it's characterized by repeated vomiting after feeds, which is what this one had, leading dehydration, which this one doesn't necessarily ever show any signs of dehydration or hypokalemic metabolic acid alkalosis. They're just not growing. So gastroesophageal reflux disease, very common in infants. Okay, diminished closing pressure of the lower esophageal sphincter, sure, not a big deal. If they have good weight gain, feeding well, not irritable, you can manage it conservatively with lifestyle interventions. However, patients like this who are losing weight, they might need some ultrasound testing. You might even try a PPI in order to prevent the worsening of this. Formula-fed children may require thickened feeds or transition to breast milk in order to improve their condition.